congratulate office bearers of IAP Calicut. And this week, the mentor is Dr. Priya S., who is Assistant Professor, Government Medical College, Calicut. And the case is being discussed by Dr. Fiji, MD, who is our Associate Professor. And she's a very good academician and a very good clinician. And the case is presented by Dr. Emil, who is our JR3. So, I would like to invite Dr. Riaz, IAP President, Kerala IAP, to say a few words.
So, respected Mohan sir, who is the chair of this meeting, Anandageshwan sir, Purushothaman sir, Srinivasan sir, Dr. Fiji, and all the respected teachers as well as seniors and students here. So we are actually opening another edition of IAP Kerala PG Club, and now we are maintaining a variety. We had one lecture, we had an OSCE, now it is a case discussion. And I'm happy to announce that next month, Kusuma Madam, we should say the mother of pediatric oncology in Kerala, she has agreed to deliver a lecture. So that will also come soon. So without wasting much time, I congratulate the Calicut team for all the efforts. And I congratulate Dr. Priya and Dr. Fiji, and also offer my best wishes for the students. Happy learning. Thank you.
Anandageshwan sir?
So we'll start the program without wasting time. Okay.
Okay.
So we start the program.
Fiji, you can start.
So first of all, I thank Mohan sir for giving me this opportunity. Riya sir, thank you for inviting me to this program. I am not a regular attendee of this program, but I used to attend whenever my home work and all are over. And I enjoy all activities of IAP. So today we have a case from nephrology. We had a similar discussion few months back by Krishnan sir. So I will be concentrating more on the treatment aspect and all of this case. And this may be more of a OSCE type or a Viva OSCE type for the students, because the case, we will see the case and then you will understand. So what we discussed in the last case of nephrology from KOZHIKODE, I will start from that. So the clinical presentation and all were mostly discussed by Krishnan sir last time. And let us see what Emil Joy has to say in the case. Emil, can you start?
Okay, madam. Good evening to all. Myself, Dr. Emil, Junior Resident, IMCH Calicut. Today, I am presenting the case of 9-year-old boy hailing from Thanur, Malappuram, whose informant is mother and she is reliable. And I examined the child on 6th of May 2025. So the child with the recurrent episodes of facial puffiness and leg swelling for the past 6 months, now presented with increased weight gain for the past 3 months and admitted for some invasive procedure as a part of treatment. History of present illness. 9-year-old boy with the history of recurrent facial puffiness and leg swelling, and diagnosed with a renal disease at 2 years of age on some medications, now presented with increased weight gain for the last 3 months. The weight gain was gradual in onset, and mother initially noticed chubbiness of cheeks followed by abdominal distension and tightening of clothes. There is history of increased appetite with the portion size significantly increasing over the last 3 months. His diet mainly includes 3 major meals and 2 snacks in between. He used to go to school by auto and he used to involve in outdoor activities 1 hour daily after returning from school. His daily screen time is limited to 1 to 2 hours, mostly spent on a mobile phone. No history of sleep disturbance in the form of night awakenings or snoring. No history of cold intolerance or altered bowel habits. No history of recurrent muscle pain, and no history of pain or redness of eyes or blurring of vision.
Okay. So that is your present history of present illness.
Yes, madam.
Okay. Go to the first slide of history of present illness. So here, Emil is talking about a 9-year-old boy having some renal disease that we will see in the past history, and he's on treatment from 2 years of age. And the problem started, as far as she is concerned, for the last 6 months, and has recurrent puffiness and leg swelling for the last 6 months, for which he is taking regular medications. And the current admission is for increasing weight, isn't it, Emil?
Yes, madam.
So she may be, what she may be talking about is obesity, or probably maybe iatrogenic due to the treatment. So what are the important points that you try to mention as the as part of this obesity?
Here the obesity started 3 months back with in the form of abdominal distension and tightening of clothes, and maybe it may be associated with some drug intake, because the child is a non-case of renal disease, diagnosed at 2 years of age, and on some medications for the on some daily medications for the last 6 months. So here I try to rule out other causes of obesity, because there is no history of any cold intolerance or to rule out hypothyroidism. And
so why you told about this chubbiness and abdominal distension?
To mention the type of obesity, maybe central obesity.
Okay, central obesity means abdominal distension.
Abdominal distension.
And this chubbiness?
Chubbiness may be part of Cushinod facies due to iatrogenic causes.
So you are suspecting some steroid toxicity, isn't it?
Yes, madam.
Okay, chubbiness of cheeks. So can that be due to this renal disease, edema?
In renal disease, the edema will be mainly around periorbital region, and it's and also the dependent part like leg, or in case of bilateral pedal edema.
So you could have mentioned that there is no periorbital puffiness or leg swelling here itself. Abdominal distension can also occur due to ascites in this context.
Yes, madam.
So it will be better to mention that there is no periorbital puffiness and there is no diurnal variation for the facial puffiness. And it's mainly chubbiness of cheeks. Okay. And increased appetite he has mentioned. And you will be going into the details in diet history, isn't it?
Yes, madam.
Okay. Next slide. It's not moving.
So I cannot change the slide.
You take it into stop the slideshow and then move.
Stop the slideshow and again screen share stop ചെയ്തിട്ട് ഒന്നുകൂടെ സ്റ്റാർട്ട് ചെയ്തു.
So this today I will try to conclude my session by 8:30 to 9. So I will be going to the points alone. And if anybody has any doubts, you can intervene in between. Okay. She also mentioned the daily activities. He is going by auto, but child has outdoor activities. Screen time also she mentioned. So what is the guideline IAP stand on the obesity prevention? What is 5210 rule? Emil, can you tell what is 5210 rule? As part of prevention of obesity. Do you know?
Age-wise screen time, madam.
No, 5210. 5
Uh,
hours screen time is allowed by IAP?
no, madam. 5 times servings of
Yeah,
the
Mary has
vegetables.
written 5 portions, 5 servings of fruits and vegetables per day. What is this 2 standing for?
2 for the screen time, madam.
Yes, 2 hours of screen time in all ages.
In less than 18 months, there is no screen time allowed. In 2 to 5 years, it's 1 to 2 hours. More than 5 years, it's 2 hours.
Very good. So more than this child is 9 years, so 2 hours screen time can be allowed, and 1 for 5210. 1 for
Physical activity, madam. 1 for
very
physical
good,
activity.
very good. So vigorous physical activity for 1 hour per day, and 0
Intake of sugary beverages.
sweetened beverages, 0
We should avoid.
Once in a month or 2 weeks they can take. So daily sweetened beverages 0. So this is to prevent obesity. And here, can I ask the definition of obesity?
Obesity is, according to IAP, if the BMI is above the
That is the
27th
cutoff. What is the when will you consider it as obesity?
when the body mass index is above +3 standard deviation, or it is more than 20.
So I can
27
say
adult.
that obesity is when the body fat, dysfunctional body fat is more and is impairing the health of the baby. Okay. And the cutoff is 27th adult equivalent.
Adult.
27th adult equivalent. It is not centile, Mary. It is not 27th centile. It is the 27th adult equivalent. That is obesity. And when will you say overweight?
When it is more than 23rd and less than 27 adult equivalent.
Okay.
It's called as overweight.
Okay, so that is regarding obesity. So it is obesity is increase in the body fat, dysfunctional fat that is impairing the health of the child or the person. And for younger children, better to say go by weight for height. After 5 years, we mainly depend on BMI. And before 5 years, it is weight for height. How will you classify that obesity and overweight? Below 5 years?
More than 3 standard deviation.
Yes. And between +2 and +3 standard deviation, it is
overweight.
Overweight. So that we have. So we will go to the anthropometry and we'll find whether child is obese or is it just mother's perception. And his screen time is also okay. Then no sleep disturbances. Maybe to mention that there is no obstructive sleep apnea, isn't it?
Yes, madam.
You can also mention lethargy or inattention during the class time. That also may be a sign of sleep disturbance. And cold intolerance for hypothyroidism problem.
Hypothyroidism.
So what are the causes of pathological obesity? Endocrine causes, can you say 3?
Endocrine causes can be due to Cushing syndrome or
Yeah.
growth hormone deficiency.
Growth hormone
Hypothyroidism.
deficiency, they may become obese in the laterhood.
Hypothyroidism.
Hypothyroidism, Cushing syndrome, and one more.
Prolactinome.
No, it is pseudo hypoparathyroidism. So 3 main causes of obesity due to endocrine cause, we can say hypothyroidism, Cushing syndrome, maybe iatrogenic or endogenous, and then pseudo hypoparathyroidism. And recurrent muscle pain, why you mentioned that?
Maybe as a part of obesity, there will be chance of myopathies or
Obesity will
osteo.
cause myopathy or steroids?
or steroid-induced
Steroids. What type of
my
myopathy? Proximal, distal,
proximal myopathy,
proximal. What will be the symptom?
mainly symptoms on climbing up the stairs or
Okay. There may be some waddling gait and difficulty in getting up from
getting up from sitting position.
squatting position or climbing stairs may be difficult. Okay. And pain on redness of eyes. Why?
As a part of steroid-induced.
Okay, so you have already concluded that it is probably due to steroids and you are asking for other symptoms of steroid toxicity, isn't it?
Hello.
Yes, sir.
Hello.
Answer.
എന്റെ സിസ്റ്റത്തിന് എന്തോ ഒരു പ്രശ്നമുണ്ട്. ഞാൻ ഹോസ്റ്റാണ്. അപ്പോ ചിലപ്പം ഓഫ് ആവുകയാണെങ്കിൽ ഒന്നുകൂടെ റീജോയിൻ ചെയ്യേണ്ടി വരും.
Okay, sir. Okay. So that is to look for glaucoma.
Raised intraocular pressure as a part of complication of steroid.
Okay. So if you are suspecting such steroid toxicity, what else you can ask? Sometimes hypocalcemia, tetany can occur if they are not on supplements, fractures can occur, back pain, vertebral compression and all, hip pain, all these can occur. And obesity itself can cause knee pain, hip problems due to slipped capital femoral epiphysis. All this you can ask. And child was not having this weight gain before. Maitri, can you mute your phone? Okay. So in this history of present illness, you are just giving as a clue that child is obese and you think it is due to the treatment, isn't it?
Yes, madam.
Okay. Can we go to the proper disease? It will be in the past history. Anything to add, sir? Purushottam, sir? Okay, we will anything to add.
In a case like this, Emil, from 2 year onwards, child was on diagnosed renal problem on treatment.
Yes.
The weight gain is there for the last 3 months only, according to you. Okay.
Yes, sir.
Okay. The details of the treatment you should have mentioned, because it need not be steroids only. There can be other drugs also which can has got a propensity for this overweight, or there are possibilities of endocrinological problems also induced by the drugs. In a case like this, first possibility is to differentiate between true obesity or any sort of an edema. In a case like this, the first point already Fiji has pointed out, if it is due to edema, the diurnal variation and the appearance difference between the morning and evening of the facies will be helpful. That will happen only if it is an edema.
Okay.
In a non-case of renal condition, there is no rule that other system involvement cannot be there, because hypertension leading on to congestive failure due to a chronic renal problem. So you didn't mention about the dyspnea part and the possibility of a cardiac element responsible for the edema condition. Okay. Then in the hypothyroidism is definitely very important, because for the last 3 months it is happening. So bowel disturbances and other things, higher functions, sleepiness, and all the other features of hypothyroidism you need to mention in the history. So just because the patient is diagnosed with a renal disorder, for the last 7 years she was tolerating like that. So is it the renal disorder progressing to a complicated state, which again can lead to edema due to multiple reasons, maybe due to other system involvement, maybe due to another endocrinological problem, or the drug use for this thing. So all these possibilities you need to consider in the history. and the points would be there to differentiate between all the possibilities. Okay, that's all.
Yes.
Okay, sir. So, Emil, can you mention some other drugs which can cause obesity other than steroids?
Mm.
We had recently in our ward. So, anticonvulsants like valproate and carbamazepine can cause weight gain. And also antipsychotics, we see children, our own students having psychiatric illness becoming very obese because of olanzapine, risperidone, etc. So antipsychotics are also known to cause weight gain. So that also you have to consider. And we don't know whether this is the nature of the child, it is exogenous obesity or not, because 9-year-old now the child has become obese, may not be iatrogenic. So how will you identify whether it is exogenous or endogenous obesity? What other question you should have asked?
Regarding the height velocity or
Very good.
regarding
So the height
eating
is a
pattern.
very good marker towards exogenous or endogenous. So height deceleration of the growth will be there. Height velocity will be reduced if it is steroid induced. But in exogenous, they will be tall and heavy. So that will also help. And the family history and all, we will go into the details, diet history and all. So can we go to the past history?
Yes, madam.
Okay.
In this case of a long duration problem, in a real life situation, what you should be asking for is the photographs of the previous years, maybe birthday celebrations and all. You can clearly make out what is the pattern of this weight gain. What about the height pattern? Or maybe you can ask about the relation with the other students in the batch. Maybe at the time of LKG, she may be the tallest among the 40 numbers, and over time she will go into the last. So comparing the previous photographs will be very helpful in a chronic disorder like this, which will affect the height and weight. Unless you analyze the growth chart and all, you cannot comment about this thing. So points in the history which will help you in the commenting about the weight and height is like this.
Yes. So I will have to mention about the height. Okay. Parents' perception about the height increment.
Okay.
So let us go to the past history.
Past history. Child was apparently normal till 2 years of age. Then he presented with a fever and bilateral leg swelling for 2 days and decreased urine output for 1 day. No history of any genital swelling, abdominal distension or breathing difficulty at that time. No history of red-colored urine. No history of any preceding pyoderma or throat infection. So child was evaluated and started on some oral medication in the form of tablets on day 2 of admission. It was taken daily as 2 divided doses. So edema improved within 1 week of starting treatment and was discharged on that oral medication. And they were advised to continue daily medications for 6 weeks and on alternate days for the following 6 weeks. Bedside urine tests were performed daily and no abnormality noted during the course of treatment. After discharge, no history of edema during that period. Drug compliance was good. Drug was tapered and stopped by November 2017. After 2 months of stopping medication, child again developed similar symptoms. This episode was preceded by fever, cough and rhinitis for 2 days. Bedside urine test was also abnormal and child was started on similar medication which was given previously and it was given on OPD basis. No hospital admission required. Edema subsided within 5 days of starting the medication and it was tapered and stopped over next 2 months. Thereafter, child got similar episodes requiring similar oral medication for 2 to 3 months of duration. Then in the year of 2018, child got 2 such episodes with a gap of 6 months duration and 1 required hospitalization as the child was having abdominal distension, abdominal pain, lethargy along with significant edema. And this time, child was treated with some IV medication for 7 days. In 2019, had 2 such episodes treated with oral medication for longer duration and no hospital admission required. Eye examination was also done at that time and said to be normal, advised 6 monthly follow-up. Then for the next 5 years, from 2019 to 2024, child required multiple short course oral medication 2 to 3 times per year following upper respiratory infection, and they were under regular follow-up. Then after 5 years, in April 2024, child again developed similar episode. It was associated with massive edema involving genital area and abdomen, admitted and managed with oral medication, which was tapered and stopped over next 3 months. Then symptoms recurred after 3 months of stopping medication and was treated appropriately. Then in January 2025, while on alternate day medication, which was started 2 months back, child again developed abdominal distension and leg swelling. This time, child was admitted and continued daily medication, started on another medication also in tablet form in view of frequent symptoms. Then one month later, in February, child developed similar symptoms, which was preceded by cough and rhinitis while on 2 types of oral medication. One was taken daily and another was on alternate day basis. Then last ophthalmic follow-up was done 1 month back, noted to have increased pressure according to mother and not started on any medication. They were advised 3 monthly follow-up. Now child is currently taking 2 types of oral medication and an investigation was done 2 days back and added another medication in tablet form.
Okay. So, Emil, now you have narrated a long history from the age of 2 years. Now the child is 9 years. It's a boy. So, in the beginning, I have a doubt whether it was leg swelling in the beginning or was there any facial puffiness also?
Facial puffiness was also there, madam.
Okay.
Along
So
with
since
leg
they are
swelling.
getting recurrent edema and they may not give much importance to where it started. So that is the problem with the chronic cases. You have to specifically ask whether it was in the face because for mother, they are seeing edema on and off for last 7 years. They may not give much importance. So you should correct if it is wrong. So it usually starts in the face, isn't it?
Yes, madam.
And is the urine output, decreased urine output common in this setting?
If there is edema, there is a state of hypovolemia, but decreased urine output is not very common.
It can occur if there is hypovolemia, but with the 2 days history, it is not very common. If they have not given much importance and didn't take treatment for 1 or 2 weeks, child will have severe edema and then there can be decreased urine output. So that days and all may be wrong. 2 days history and decreased output may not be correct. That also you can cross check. And so what is the main presentation in the beginning? Child had an infection along with probably generalized edema without any oliguria, hematuria and all, isn't it? Oliguria was there, no hematuria.
No hematuria.
So, can this be acute glomerular nephritis? If not, why?
There is no history of any preceding like pyoderma or throat infection. No history of hematuria also. So in acute glomerular nephritis,
any other point which is against AGN here? In the first, with the first paragraph alone.
Because there is edema.
Edema can occur in AGN also.
Abdominal distension.
Abdominal distension, you have not mentioned. No history. There is no abdominal distension. So
there is no.
The age is against 2 years only. So at 2 years, we expect more of nephrotic syndrome. Okay, so it is in the school going age group that AGN is more common, and fever with the edema together happening. That also is common with nephrotic syndrome. In AGN, it is post-infectious. No? There is a history of fever, and after 2 weeks or so, child develops swelling. Along with swelling, there won't be fever in AGN usually. Sometimes it can be para-infectious or along with infection, rarely. So from the first history, you think that it is nephrotic syndrome, isn't it?
Yes, madam.
So what do you think? Is it a minimal change disease or is there anything atypical?
The age group is 2 years. Between
Is it
2 to 8
atypical?
years, no, it's typical. In 2 to 8 years, we commonly expect minimal change disease. If it is
Any other clue to think that it is only minimal change disease or it is not significant lesion nephrotic syndrome?
there is no hematuria.
Good.
And
No hypertension you have mentioned, no breathing difficulty, and child responded to the treatment.
well to the treatment.
So it is probably minimal change disease. Can I ask Nirmala John, how will you diagnose nephrotic syndrome? What is the criteria to diagnose nephrotic syndrome? Nirmala is there? Anybody from IMCH Bestin?
Madam, nephrotic range is proteinuria.
Okay. What is that?
Which
What is nephrotic range proteinuria? When will you say? You can say
more
fast so that we can go and complete with till 9 o'clock. What is nephrotic range proteinuria?
more than 3 grams per day.
That's for
Total
adult.
protein.
So here it is a different weight, no? For different children have different weight. So we can't say 3 gram.
Video.
What is that? It is if you are measuring 24-hour urine, more than 1 gram per meter square. It is based on body surface area. 1 gram per meter square per day or 40 milligram per meter square per hour. Or if there is 3+ proteinuria in the dipstick or the PC ratio more than 2. More than 2. So the reliable ones are 24-hour urine and PC ratio. 24-hour urine more than 1 gram per day or PC ratio more than 2 is called nephrotic range proteinuria. And less than 0.2 is the normal protein content in the urine. So between 0.2 to 2 is proteinuria but not nephrotic range. So there should be proteinuria. What other point should be there to say nephrotic syndrome?
Total cholesterol more than 200.
No, in the current guideline, 2021 guideline, cholesterol is not a criteria. So we have 3 criteria. One is nephrotic range proteinuria. Second is edema. Third is hypoalbuminemia. It was 2.5 earlier. Now it is 3 gram per deciliter. So these 3 should be there to diagnose nephrotic syndrome according to ISBN. But according to KDIGO, they say there should be nephrotic range proteinuria and one of the following, hypoalbuminemia or edema. That is enough to diagnose nephrotic syndrome. So we have diagnosed nephrotic syndrome. And next is regarding we will go to some definitions. It will be useful, I think. So when will you say remission? They have started some oral medication and 1 week, within 1 week, child improved and discharged. So what is meant by remission? Emil?
Madam, complete remission means the urine PCR in the first morning sample or the 24-hour urine sample is less than 0.2 milligram per milligram, or urine PCR is nil or trace in dipstick or heat and acetic acid test.
PCR is less than 0.2 and dipstick
less than 0.2, and the urine albumin is nil or trace in heat and acetic acid test or dipstick test, which is performed for 3 or more consecutive days, and there should be disappearance
3
of
days is enough. 3 consecutive days. That is
days and
an absence of edema.
edema.
Okay. And when will you say relapse?
When there is relapse, the urine albumin will be more than or equal to 3+ for 3 consecutive days with or without edema, and the urine PCR will be more than or equal to 2 with or without edema, and or edema of any degree, edema with any degree of proteinuria.
Very good. So here we have to see once in remission, child again develops. That should be there. Child was in remission and then developed 3+ proteinuria for 3 days, PC ratio more than 2, or any range proteinuria with edema in a child already diagnosed to have nephrotic syndrome is called relapse. So with that, what is your comment about improvement of edema within 1 week? Is it a good sign or bad sign? Is there any relevance for that?
It's a good sign, madam, because it indicates that the first episode was a steroid sensitive episode. So the steroid sensitive nephrotic syndrome.
So 1 week is the cutoff for steroid resistance?
No, madam. For steroid sensitive, it should be 4 weeks, and for resistance, it should be 6 weeks.
There is no need of such classification. Steroid resistance means even with the 6 weeks of daily 2 mg per kg steroids, proteinuria is persisting, not attaining remission. That is steroid resistance. There is no need of 4 weeks there. Only 6 weeks that you have to remember. What is the relevance of getting remission within 1 week? It is an early responder.
Minimal, maybe minimal
Early
change.
responder, so probably has a better prognosis than a child who improves after 2 weeks or 3 weeks of steroids. So 1 week is good as far as child is concerned, and we have given the medication for 6 weeks and an alternate day for 6 weeks. So if just to refresh your memory, what is the treatment of first episode of nephrotic syndrome? Can I ask first year JS? Tamil is there? Tamil Bharati? Any JR1 from IMCH? Or Bestin, can you say? I can see your name. First episode of nephrotic syndrome, how will you treat? So we are giving 2 mg per kg steroids for 6 weeks daily in divided doses probably.
Divided dose 2 mg per kg per day. In divided dose for 6
weeks. And then we will give 1.5 mg per kg single morning dose.
And then 1.5 mg per kg in single dose on alternate days.
For
6 weeks.
6 weeks. And then we will taper and stop over 2-3 weeks. That is the typical treatment of first episode of nephrotic syndrome. And what if there is a relapse? That all know. 2 mg per kg we will give till the child attains remission. That is urine albumin nil for 3 days, and then we will change to alternate day.
To alternate
that
days
will
once,
be continued
once the remission obtained.
Up to 4 weeks.
4 weeks.
Maximum, usually they attain remission within 2 weeks. So it's 2 weeks plus 4 weeks regime for the relapse. Okay. Next slide, Emil. And they have done bedside urine test. It is probably heat and acetic acid test. How will you do that? Can you tell the procedure, Emil?
Yes, madam. Here we have to take the early morning urine sample in a
Why
test tube.
early morning?
To prevent the orthostatic proteinuria, there will be.
Okay. So it is the first voided sample that we take. Then
it should be taken up to 2/3 of the test tube, and it should be heated using lamp and the 2 centimeter upper column using the lamp. And after boiling it, we have to add 3 drops of acetic acid, 1% acetic acid we have to add. Then we have to look for the color of the upper 2 centimeter of that urine column, and we have to interpret accordingly. If it is clear, then there is no proteinuria, and if there is a little haziness, then it can be classified as nil or trace. Then
Nil
if it
is
is
clear. Nil
is
means
clear
nothing.
and trace is slight haziness,
Okay.
then 1 plus means there is clear haziness is there, but when a paper is shown against the test tube, the small prints can be read easily.
Okay.
Then 2 plus means the whiteness should be there, but
Okay.
when the paper is placed against the test tube, the small prints can seen but cannot be read, but the larger headlines can be seen and read.
Okay.
And then 3 plus means there will be milky appearance, so that the large headlines cannot be seen and cannot be read. Then 4 plus means there is a curd-like dense flocules will be there.
Okay, so we can also think that if there is precipitate, curd-like precipitate, it is 4 plus. Significant color, not a risk, it is 3 plus. And below that is 2 plus, 1 plus, and trace. Okay. And why we are adding this acetic acid? Sometimes there can be white color because of phosphate precipitates. So to dissolve phosphate, we are adding acetic acid. An acidic medium that will disappear. So if the white color disappears on adding vinegar or acetic acid, it is definitely protein. That is it. And we can use sulfosalicylic acid also instead of that. There is no need of heating. Just adding sulfosalicylic acid is enough. Other method is dipstick. We have the glucose strip, the strip light, which measures pH, hematuria, and proteinuria in the single strip. And it is costly. So we ask them to cut it longitudinally so that one strip can be used for 2 days. If they have, they can do that. And what we recommend usually, whether they should do it daily. What is the use of doing this at home?
Till attaining remission, this has to be done daily.
Okay.
Then, while on alternate day steroids, this has to be done on in alternate days.
Okay. 2 to 3 times per week. And
Per
what is
week.
the importance of doing it?
Early recognition of relapse.
So the mother can recognize the relapse early. Even if the child is in remission, when the child gets fever or when they feel that there is mild puffiness, they should definitely do the test for the next few days daily so that early relapse can be identified before edema develops. So early identification helps to give the small dose of steroids for 1 week or 5 to 7 days so that a relapse can be aborted. What is that called? Getting proteinuria during infections.
Infection-induced proteinuria.
Yes. So there is an entity called infection-related proteinuria that can be aborted without this relapse treatment just by giving 0.5 mg per kg steroids for 5 to 7 days daily. That's the importance of doing bedside urine test. Okay. And they can also identify relapse early so that massive edema need not occur. Once they develop massive edema, these drugs may not work properly. Child may require admission, and all these can be prevented by identifying it early. So, as you know, in our clinic, they are maintaining a separate book and date.
Abhisha, can you mute?
Mute.
Abhisha,
Many are talking.
Abhisha, can you mute?
Okay. So that should be maintained and that require parent counseling and also proper instructions regarding this test. So here drug compliance was good. And what happened for the first few, after 2 months, child again had relapse, isn't it?
Relapse. Yes, madam.
So is it a frequent relapsing nephrotic syndrome? When will you say frequent relapsing nephrotic syndrome?
In case of frequent relapsing nephrotic syndrome, there should be more than or equal to 2 relapse within the 6 months of initiation of treatment of steroid, or there is more than or equal to
here, Emil, it is not within the initiation. After completing the treatment of first episode, in the next 6 months, if they get more than 2 relapses, it is called frequent relapse. That is one criteria. 2 more are there. What are they?
more than or equal to 3 relapses in any 6-month period or more than or equal to 4 relapses in any 12-month period.
Okay. So earlier there were only 2 criteria, that is 2 or more relapses in the first 6 months after initial treatment, 4 or more relapse in any 1 year. That was there. And they have added 1 criteria recently, that is 3 or more relapse in any 6 months. So 3 criteria are there for FRNS. All others are infrequent relapsing. So what is the relevance of identifying FRNS?
In FRNS, we have to maintain shorter low dose steroid for a longer time.
Okay.
To avoid and there will be any chance for steroid induced complications also.
Okay, so those children require more frequent follow-up and the toxicity screening should be administered. Otherwise, infrequent relapsing nephrotic syndrome doesn't require much regular follow-up or screening for toxicity. Sir, I have to make co-host?
In that case, I can manage those who are switching on and talking in between.
Okay. How to do that, sir? Host tools.
Against my name, there will be 3 dots. In that, you can get the option of making
Okay.
co-host.
Okay. Co-host. Okay. I have done.
Now you continue.
Okay. So here, was this child frequent relapser initially?
No, madam.
And what precipitated that relapse?
The second relapse was precipitated by an upper respiratory tract infection.
Okay.
Fever, cough, and rhinitis was there for 2 days.
So that you should remember. For a child with nephrotic syndrome, relapses are usually precipitated by infections. And of the infection, it is just trivial viral upper respiratory infections. So proper hand hygiene and using mask, respiratory hygiene, all can prevent relapses in a child with nephrotic syndrome. And probably if it was diagnosed early, we could have aborted it with a short course of steroids for 5 to 7 days. Okay, bedside urine test. Okay, that was given on OP basis. So here it was treated OP basis. First episode was admitted. Child was in the hospital. Why that happened? What is your comment? Can we treat the first episode on OP basis?
We can treat, but the first episode should be always be admitted because we have to counsel the parents regarding the nature and cause of the disease and regarding the need for medication, and we have to teach the parents regarding the procedure of that bedside urine albumin test.
Okay.
And
so
that we have
give some importance to the disease and the need of follow-up, it is always better to admit the first episode. Okay, next slide. So after that you are mentioning, for the next few years, child had relapses not very frequently, isn't it? And in
Yes, ma'am.
2018, child required hospitalization. So
Yes.
why there was abdominal distension, pain and lethargy along with significant edema? So in a child with severe edema, if they complain lethargy, abdominal pain, what will you suspect? This
Madam,
child
in
is
this case, we have to
3-year-old.
suspect chance of spontaneous bacterial peritonitis because there is abdominal pain, lethargy. So if there is spontaneous bacterial peritonitis, we have to start IV antibiotics.
Okay. So how will you confirm that it is spontaneous bacterial peritonitis?
By ascitic tap. We have to do ascitic tap and we have to examine the peritoneal fluid, and there should be neutrophil more than 250 per microdeciliter of the peritoneal fluid.
WBC more than 100 is enough. More than 100 WBC, 50% neutrophils. That is enough to diagnose SBP. But it was normal. Ascitic fluid tract was normal. So why this pain, lethargy happened in a child with massive edema having a relapse when complaining of pain and lethargy? What else will you suspect?
Maybe hypovolemia.
Very good. So this is a sign of hypovolemia. Whenever child has a massive edema, we should always think of hypovolemia. And one of the manifestation is abdominal pain, lethargy, and then urine output will be reduced, tongue will be dry. So we cannot depend on the synchronized delayed skin pinch and all because there is edema. So the reliable signs of dehydration or hypovolemia in a child with edema is mouth, oral cavity will be dry, pulse will be very low volume and tachycardia will be there, urine output will be reduced, and there will be abdominal pain, lethargy, CFT prolongation means very advanced state going into shock. So we have to diagnose hypovolemia early. And can I ask for any investigations to identify hypovolemia? Maybe.
We can do RFT. There will be increased serum urea will be there, and hematocrit will be there will be more than 10% increase in hematocrit compared to previous value in case of hypovolemia.
Regarding blood urea,
there will be increase in blood urea levels.
Can that be due to AKI? Due to
In
intrinsic
AK,
renal problem?
in AK, the creatinine will
So the
also be up.
ratio is important. Urea creatinine ratio will be more than 100. That is there. Then there will be hematocrit increase. Anything else?
Fractional excretion of.
Okay, for theoretical purpose, we can say that we are not routinely doing FeNA will be more than 0.5. And what is FeNA?
Fractional excretion of sodium.
Urine sodium into serum creatinine divided by urine serum sodium into urine creatinine into 100. That is fractional excretion. And the potassium index will be more than 0.6. So the sodium retention, potassium loss in the urine. What does that indicate? Salt water retention and potassium wastage. Which hormone causes that?
Aldosterone.
Okay, that is indicating hyperaldosteronism due to hypovolemia. So when there is hypovolemia, FeNA will be decreased and potassium index in the urine. That is the urine potassium divided by urine sodium plus urine potassium. That will be more than 0.6. And anything else you do in the PICU to identify hypovolemia?
IVC collapsibility.
Yes, IVC collapsibility will be more. And then BP and all, shock and all indicate the late stages of hypovolemia. So that is an indication for admission. In a child with relapse, if there is hypovolemia, we have to be careful. Why?
Because there is chance for cerebral venous thrombosis.
Any other site where thrombosis can occur?
Renal vein thrombosis can also.
Okay, so the renal vein or cerebral vein thrombosis. Then any other complication? Pre-renal AKI can occur. And this massive edema will cause gut edema. So our steroids may not get absorbed. Furosemide may not work. So all the complications, sepsis chance is more. So that is a complicated relapse. So when a child has massive edema, hypovolemia and all, it is complicated relapse. So when will you say complicated relapse? Ashwati, Sunil? When will you say complicated relapse in nephrotic syndrome? Ashwati is not responding. Who else is there? Anjima? When will you say complicated relapse? We'll say complicated relapse if there is thrombosis, SBP, or severe hypovolemia. All these are complicated relapse. So that is important to decide further treatment, whether child should be on steroids alone or should be on a second line agent. That is the importance. So identifying complicated relapse and identifying steroid toxicity. Okay, next slide. Okay, then for the next 5 years, child required only multiple short course medications. What does that indicate? Multiple short course means? You have mentioned the dates or duration. Short course can be 1 week or 1 month. What do you meant?
It is less than 1 week only, madam.
Okay, so it was all infection-related proteinuria, and that will not cause much toxicity, and child was under follow-up. Okay. Next slide. Then what happened? For the last 1 year, child is getting problems. Massive edema once. So edema involving thigh and genital area, that indicate massive edema.
Mass.
Or how will you classify edema depending on weight gain? Do you have any
If the
idea?
mild, moderate, and severe edema. If the weight gain is more than 15%, it's severe edema. If it is between 8 to 15, it's moderate. And if it is less than 8, it's mild edema, according to
7% weight gain. So one important order in the case sheet will be daily weight measurement.
weight monitor.
That is very important to identify edema. And then child was on long-term alternate day medication, isn't it? From January?
Yes, madam.
Long-term medication. So what is your comment about the long-term alternate day steroid treatment? How you give it?
By
Acceptable dose.
can be low dose steroid,
What is meant by low dose?
0.5 to 1 mg per kg per.
Not
mg
1
per
mg, 0.5 to 0.7 mg.
0.7.
Maximum 0.7 mg we can give alternate day for how long?
Can be 6 months.
6 to 12 months. We can give that for 12 months, provided we are monitoring for steroid toxicity in the form of hypertension, glaucoma, cataract. We will look for osteoporosis, short stature, striae, obesity. All these we have to follow, monitor. If nothing is there, we can continue for 1 year at 0.5 to 0.7, but better to reduce it to less than 0.3. 0.3 will be very safe. Can we give that day on daily basis, or why should we give on alternate day?
Can be given on daily basis in case if there is any infection-induced albuminuria.
Okay, so when a child is on alternate day medication, if the child gets fever and mild proteinuria, they can change the same dose to daily regime for 7 days, just to avoid that relapse, and then continue the same dose alternate day. I am asking whether we can continue 0.3 mg daily for 1 year. Is it accepted? What is the problem?
There will be a suppression of HPA.
Yes.
Axis.
So even if the dose is same or even lower than the alternate day dose, if we are giving it daily, that was significant pituitary suppression. So we won't prefer daily treatment of steroids. Okay. So here the child had some complicated relapse in January and started on another medication. So what are the other drugs other than steroids? Second line agents in nephrotic syndrome.
We can use steroid sparing agents like levamisole, mycophenolate mofetil, and then calcineurin inhibitors like cyclosporin and tacrolimus, then cyclophosphamide, or
all are steroid sparing?
Cyclophosphamide, cyclosporin, and mycophenolate mofetil.
We can say that we can reduce the dose of steroids with levamisole, MMF, and cyclophosphamide, but we may have to continue steroids at a lower dose along with this. We can use it alone. CNI is probably more powerful and can reduce and even stop the steroids very early if you are starting tacrolimus or cyclosporin. Okay, so these are the second line agents. Main 3 second line agents are levamisole, MMF, and cyclophosphamide in the order of toxicity or profile or safety profile. So of the 3, how will you choose? What may be the medication this child was started on? How will you decide whether I should start levamisole, MMF, or cyclophosphamide?
Here,
which is the least potent of the 3? Least potent is
Mm.
levamisole. It's least potent. So if there is a frequent relapse and not tolerating steroids, we can try levamisole, provided child is not very young in age. In young children, it may not work. And the safety profile, cost, all will be better for levamisole. We can continue it alternate day in 2 to 2.5 mg for 2 to 3 years even. Up to 2 years, we can continue without much problems. What will you monitor while the child is on levamisole?
While on levamisole, we have to monitor CBC, and then SGPT and SGOT we have to monitor. Then there will be chance for ANCA-related vasculitis also. So if the patient develops any rash or
Okay, so
vasculitis like
leukopenia, any vasculitis, we are not seeing any such cases. Leukopenia sometimes we see, and child will be little immunosuppressed. What if the child is on MMF?
in MMF, we have to look for leukopenia. CBC we have to do. Also, there will be liver enzyme abnormalities. So we have to do SGOT and SGPT.
What is the common complaint with the MMF patients?
Abdominal pain.
Yes, abdominal pain, discomfort, and vomiting, all will be there. So the GI symptoms are more with MMF. It is costly also and stronger immunosuppressant. So they may get viral warts. Wart is more common with MMF. And we will continue it for 2 to 3 years at the dose of 25 to 30. In usual case, maximum 40 milligram per kg. It is to be given daily, but levamisole is given alternate day. And regarding cyclophosphamide, what is to be mentioned? What you should think of?
And cyclophosphamide,
route of administration?
It can be oral and IV also. IV pulse cyclophosphamide we can give, and oral cyclophosphamide also there is 2 to 2.5 mg per kg per day. We can give it for 8 to 12 weeks. And if there is non-compliance to oral therapy, we can change it to monthly 6 doses of pulse therapy of IV cyclophosphamide. So while giving
500 milligram per meter square. 500
square.
milligram per meter square monthly for 6 months, or 2 to 2.5 mg orally for around 3 months, provided cumulative dose is not reaching above what?
160.
Yes, 168 milligram is the total cumulative dose to be given to a child, because gonadal toxicity is there more for pubertal boys. So this cyclophosphamide is also not preferred in young children below 5 years and also pubertal children, especially boys. And it can cause some vomiting, hemorrhagic cystitis, loss of hair, immunosuppression, second malignancy. All these are common with the cyclophosphamide. And with the CNI, we will stop the discussion regarding second line agent. We have 2 CNI, cyclosporin and tacrolimus. So what is the difference between cyclosporin and tacrolimus with regard to the profile, drug profile, safety profile and all? I will say cyclosporin is available in syrup form. So it can be given safely to younger children because we can titrate the dose. Tacrolimus is available as capsule. So it is not easy for a very young child to give tacrolimus because the dose adjustment is very difficult. Cyclosporin dose is 4 to 5 milligram per kg daily in 2 divided doses. Child will have hyperpigmentation, blackish hyperpigmentation, and very much hair growth. Hirsutism will be there. So it is not tolerated in school-going children. We can give in preschoolers cyclosporin safely. 1 bottle, 100 milligram per ml syrup is there. So we have to give 0.2 ml, 0.3 ml very accurately. So this dosage is little difficult. There is chance of high dose erroneously given by the mother. And the problem with the cyclosporin is that they can have this cosmetic disfigurement, AKI, soon after starting cyclosporin. Even increased potassium can occur. So we have to do RFT and potassium after 2-3 days of starting, and monthly we will do. and severe immunosuppression will be there. And cyclosporine can cause hyperlipidemia also, hypertension, hyperlipidemia. These are more common with cyclosporine. But for tacrolimus, this cosmetic disfigurement is not much, but there is chance for hyperglycemia. We had children who started on tacrolimus, which required insulin because of hyperglycemia, and we changed to cyclosporine. So the diabetes is more with the tacrolimus. Immunosuppression is there, AKA is there as for this cyclosporine. This is also to be given twice daily. It is in capsule form. Dose is 0.1 to 0.2 milligram per kg. This can be continued for 2 years along with the steroids for first 6 months. Then we can even stop steroids, continue alone on CNIs. Okay. So this child was probably started on levamisole or MMF, I think, not cyclosporine or tacrolimus. And why this child was admitted now? Next slide. This was the last slide. Okay. So even with that, child developed relapse. So when will you say difficult to treat nephrotic syndrome?
When there is a frequent relapse or infrequent relapse, which is associated with significant steroid toxicity, and it is not controlled with steroid sparing, more than 2 steroid sparing agents.
Okay, so child is having frequent relapse. We have to give steroids, but there is steroid toxicity. Then we opted second line agent, and child has failed to 2 second line agents, namely either of levamisole, cyclophosphamide, or MMF. So if 2 of them, even in spite of trying that, child is getting relapse, that child is labeled as difficult to treat nephrotic syndrome. These are also guidelines and definitions in the guidelines by ISBN. So for them, we have 2 options. What are the 2 options?
We can give rituximab
Or directly to rituximab? No, we can try CNIs, either cyclosporine or tacrolimus. And even if they are not responding or getting the complications of CNI, we can try rituximab. Okay. So rituximab is anti-CD20 antibody, monoclonal antibody, which causes severe immunosuppression for the next 6 months. So we can do weekly once IV medication, rituximab, 375 milligram per meter square. It's costly also. So after 2 doses, we will check CD19. CD19 level is 0 very often. If it is less than 1%, we can stop with 2 doses or we can give 1 more dose. So maximum of 3 doses at weekly intervals that will produce severe immunosuppression for next 6 months. After 6 months, this effect wanes off, child may get relapse. So we have to give Septran prophylaxis also after rituximab if the child is maintained on steroids or MMF after that. So with that, we will stop the discussion on treatment. So this child is now admitted for invasive investigation. What may be that?
renal biopsy, madam. It was
Why?
done 2 days.
What is the indication here?
Because here child is having significant steroid toxicity, and we are planning to add calcineurin inhibitors.
So the indications for biopsy in nephrotic syndrome, if it is a steroid resistant nephrotic syndrome, we should do. If there is gross hematuria or persistent microscopic hematuria, persistent renal dysfunction, not explained by CNI, or before starting CNI, or after 2-3 years of CNI, we may have to do. Low C3 is another indication. And in young children less than 1 year, we used to do biopsy, but nowadays genetic study is better than biopsy in congenital nephrotic syndrome or a very infant with steroid resistant nephrotic syndrome. Adolescent with nephrotic syndrome, we need not do biopsy if you are not suspecting secondary nephrotic syndrome. So this child was admitted for renal biopsy and they have started on probably tacrolimus since the child is 9 years. Okay, now quickly go to the rest of the history. You will have 5 minutes or 10 minutes.
So antenatal history, there is nothing significant. He's a second child of non-consanguineous marriage, and there is a history of gestational hypertension in second trimester.
So what is the relevance there? we had a doubt whether obesity is exogenous. So the
Exogenous.
pre-pregnancy, the weight of the mother, whether mother is obese, the weight gain in the pregnancy period, SGA baby, gestational diabetes, all these four can cause obesity in the later life. Next.
So he's born as a term baby, 2.8 kg,
We'll
carries
skip
1
that.
after birth.
We'll skip this.
So developmental is
Development was normal. Okay.
normal.
Hmm.
And diet history, he was exclusively breastfed for 6 months, then started complementary feeding. Now he's
So
taking mixed
here
diets.
we have to say that exclusive breastfeeding for 6 months prevents obesity. And we will go into the details of diet and we'll see whether child is taking junks. Can you expand junks? JUNCS, which cause obesity. Emil? You can expect such questions in the exam. JUNCS. J for junk food. U for ultra processed food. N for nutritionally inappropriate food, which has a very high calorie. And C for caffeinated, colored, and then another C for caffeinated, colored, and next C? Carbonated, and S for sweetened beverages. So junks, whether child is taking junks, we have to look for, and the protein and calorie, whether it is more than expected, and whether they have any dietary restrictions. What is your comment regarding diet in nephrotic syndrome? How will you counsel the mother?
In nephrotic syndrome, we have to counsel that during the period of relapse, we have to advise salt restriction. And regarding the protein intake,
so what are the diet items, food rich in salt? We used to study in our UG days, salt, pickle, and salted pickle, papad, and salted fish. But nowadays, we have to tell them don't take bread, cornflakes, cheese, sauce, then that lace, bingo, all these things. All these are rich in salt. So we have to consider the present generation and advise to avoid added salt. And whether they should take high protein diet?
No, madam. Moderate protein intake we can advise like.
Yes, there is no use by high protein diet. It is being leaked through the kidneys. And whether they should restrict fat?
It should be less than 30% of the total calorie intake. And
In
saturated fat and trans
usual
fats.
case, there is no need of this fat restriction. Hypercholesterolemia is part of the relapse or the hypoalbuminemia. If they are on daily steroids or very difficult to treat nephrotic syndrome with the frequent relapses, they can control fat intake. Otherwise, normal diet, no added salt during illness or if they have hypertension, and adequate fluids during relapse should be confirmed. Okay. So child is getting little high protein. In our calculation, it is always like that. I think we have to revise our protein calculation in the diet. All children will be having higher protein than expected. And only not much calorie, extra calories child is getting. Next.
Immunization history, child is immunized up to age according to national immunization schedule, and he has received 2 doses optional vaccines also, 2 doses of PCV 30, single dose of PPSV 23, and 2 doses of varicella.
Can I interfere here? We can expect many questions from immunization in nephrotic syndrome. What are the additional vaccines we recommend? Pneumococcal vaccine,
varicella vaccine,
and
Haemophilus influenza. Annual
Haemophilus influenza is different from annual influenza. HIV is there in the routine schedule in the pentagon. So PCV, varicella, and influenza, the 3 vaccines recommended. And if the child is less than 6 years, check the immunization status. Now they are getting immunization with the PCV. So if they are fully immunized means 6, 10, 14 weeks vaccine with 1 booster at 12 to 15 months. If they have taken that, we give 1 dose of PCV and 1 dose of PPSV after 2 years of age. That is in a less than 6 years. If the child is not immunized, we will give 2 doses of PCV 13 and 1 dose of PPSV 23. That is in less than 6 years. In a more than 6-year-old, we need 1 dose of PCV 13 and 1 dose of PPSV 23. Can we repeat PPSV 23? Yes. After an interval of 5 years, if they are still getting relapse, we can give second dose, but not more than 2 doses in a lifetime. Regarding varicella, 2 doses, 8 weeks apart, if they have no natural infection and not vaccinated. Influenza vaccine can be taken after 6 months, 2 doses as primary doses and annual boosters. And the household contacts should not take OPV if the child is on high dose steroids or immunosuppressants. They all should take influenza vaccine, killed influenza vaccine, and varicella vaccine too if they can afford. That is regarding immunization. And hepatitis B is a must, and all other routine vaccination is a must. And while on immunosuppressants, what is your advice regarding vaccination?
While on immunosuppressant, the patient is taking high dose steroid, that is 2 mg per kg or more than 20 mg per kg. If the weight of the child is more than 10 kg, the duration is less than 14 days. We can give live vaccine after stopping the steroid. The duration is more than 14 days. The vaccine should be given only after 4 weeks of stopping steroid.
Very good. So the thing to remember is that 2 weeks is the cutoff. If more than 2 weeks, it is immunosuppressed state. 1 month gap should be there. If the child is on alternate day steroids, we can give if there is a pressing need. And if the child is on any other immunosuppressants, we have to wait for 1 month after stopping levamisole or MMF or CNI. But for cyclophosphamide, the interval is 3 months. And for rituximab, the interval is 6 to 9 months. That is it. Okay, coming to the next heading.
Family history is a second child of non-consanguineous marriage. There is no family history of renal disease, hearing impairment, or obesity.
Why you mentioned this hearing impairment here?
There can be syndromic association.
We are not expecting in this child, but routinely we are telling that Alport syndrome can have many members having sensorineural hearing loss, and they can develop nephrotic syndrome. And can minimal change disease run in family? Yes, there can be history of minimal change disease in sibling or parent that doesn't make any alteration in the treatment. If there is steroid resistant nephrotic syndrome in the family, we will do genetic study. Otherwise, if there is no dysmorphic features, it can occur in the family and the treatment is same as for any other child. And we should look for tuberculosis contact. That is important in the family history. And the obesity here may be relevant because we have a confusion whether it is exogenous. Okay. Next. IgA nephropathy can also cause nephrotic syndrome. And regarding socioeconomic status, because of lack of time, I will just mention, we should check the educational status, their access to medical care, their compliance level, and whether they have any insurance, because it is very costly treatment, long-term treatment, which involves parents' readiness to do this urine test and give drugs correctly and come for follow-up regularly. So this socioeconomic status is important. Here it is middle class family. Okay, next. Examination. Summary you can tell.
From the history, the summary is 9-year-old boy with a normal development and fully immunized, including optional vaccines, with a history of recurrent facial puffiness, leg swelling, and abdominal distension. And child is diagnosed with a renal disease at 2 years of age and on regular medication. Now he presented with increased weight gain for the past 3 months. There is no significant family history, and his diet is adequate except for some excess calories.
Whether it is 200 calories cause obesity? No.
No, madam.
Probably iatrogenic obesity. And you mentioned the raised intraocular pressure was also noted, and some invasive procedure was done, and a new drug was started. So it is probably steroid-dependent nephrotic syndrome, difficult to treat, and now on CNA. Is that okay, Emil?
Yes, madam.
Okay. Now we will go to the examination. So, since the child is not having edema or so, child has admitted for renal biopsy, we won't get much findings in this child. Suppose a child is admitted with relapse. What are the important points you should look for in the general examination?
In the general examination, we have to look for the general status, mental, because there is, and we have to look for the vitals because there is chance of hypovolemia. In case of hypovolemia, there will be tachycardia, low volume pulse, and prolonged CFT. And BP also important because it may be associated with hypertension.
Hypertension, can they have hypertension at onset or even only after steroids?
The first episode, the hypertension will be there after the initiation of steroid.
No. Some will have hypertension even at the onset, even before steroids. So we have to suspect secondary significant lesion nephrotic syndrome, or some will have some salt retention as part of the hypoaldosteronism. So there can be hypertension even before steroids. And the definition of hypertension, you should know, hope all know. In bedside calculation is 100 plus age into 3. Systolic BP above 100 plus age into 3. And for the chart, we have elevated BP if it is above 90th centile, hypertension if it is above 95th centile. That itself is divided into stage 1 and 2, where up to this 95th plus 12 millimeter, it is stage 1. If it is above the 95th plus 12, it is stage 2 of the hypertension. Okay, so hypertension monitoring is very important. We will write this in their notebook so that they can do it at the local hospital and identify hypertension. Which antihypertensive will you prefer, Emil?
If furosemide.
Furosemide, if there is salt retention or hypervolemia, usually not given furosemide in nephrotic syndrome for BP. We will give AC inhibitor because it has a protection in the form of reducing proteinuria, provided RFT is normal. Even telmisartan, losartan can also be used. Then respiratory rate is important because respiratory infection, pneumonia is a very common infection in nephrotic syndrome. Pleural effusion will cause tachycardia, CCF will cause tachycardia, even hypovolemia and stress will cause tachypnea. And they may not have fever even with sepsis. And what is the importance of identifying edema? Where all will you look for edema?
Facial, around the periorbital region. Then abdominal distension along with ascites.
Abdominal distension is edema? No, abdominal wall edema, we have to press with the stethoscope. Transverse slit-like umbilicus will be seen. If there is abdominal wall edema, we have to look for pedal edema, sacral edema, genital edema also. So genital edema indicates significant edema, vulval or scrotal edema. Okay, next.
Head to foot examination. Round faces with chubby cheeks. Head is normal in size and shape. Hair color is normal. No facial dysmorphism. No hirsutism or acne. In eyes, there is no features of cataract. No redness. Fundus is normal. In oral cavity, there is dental caries. No cheilitis. No anglostomatitis. Or no whitish patches.
Okay. In neck. Last slide. Last one. So round faces, chubby cheeks, and we will see erythema of the cheeks, thin cheeks with the capillaries dilated in Cushing syndrome. And hair hirsutism will be there, not virilization. It is generalized body hair growth. Steroids and cyclosporin both will cause hair growth. This then the cataract, this posterior subcapsular cataract is common with the steroids. We may not be able to see it. We need slit lamp to examine for cataract. And this redness you may be indicating.
Due to glaucoma, there will be red.
There is a question. Do you initiate second antihypertensive when first is at maximum? Okay. We will usually start enalapril 0.1 to 0.3. We maximum 0.6. But there is mg per kg. But there is a chance of AKI. So we will start with the 0.1 mg. Maximum 0.3 we can give. And if it is not responding, we can add amlodipine or even furosemide depending on the volume status. So redness is for glaucoma. Fundus for hypertensive changes. Then oral hygiene is very important. They can have oral thrush also. Any other finding in the oral cavity which is important in CNI?
Drug-induced, there will be hypertrophy of the gum.
Yes, with the cyclosporine, there can be hypertrophied gum. Next.
In neck, there is hyperpigmented patches, probably acanthosis nigricans, no thyroid swelling. There hyperpigmentation in axilla also. There is truncal obesity with increased fat around groin region. A normal male genitalia, prepubertal according to Tanner stage.
Okay, last slide. So here you have to look for striae also. Purple striae on the thighs and lower abdomen also indicates steroid toxicity. It is a cosmetic disfigurement, irreversible. So we may think of adding second line agent if there are significant striae also. We can have multiple molluscum, warts, tinea corporis, tinea versicolor, all indicating immunosuppression. And even a small toenail infection, onychomycosis, can also cause systemic fungal infection. So severe infections are seen after rituximab. So even the toenail infection or the fingernail infection should be treated carefully if the child is post-rituximab. Next. So this is the child. You should have mentioned that eyebrows also, very bushy eyebrows, isn't it? Chubby cheeks, double chin is there, and acanthosis nigricans. Can you see the neck and show the next? Yes.
Acanthosis nigricans over the neck.
Velvety black skin over the axilla and groin. That indicates insulin resistance. When will you say metabolic syndrome in an obese patient? What is the criteria?
Hypertension, hyperlipidemia, with insulin resistance.
Hello?
Increased waist, hip circumference.
Central adiposity. And then, so 3 out of the 5 should be there. One is hypertension, second is hyperglycemia, third increased triglyceride, fourth is HDL cholesterol below 40, and fifth is central adiposity. 3 out of 5 it is there. The chance of metabolic syndrome is, that is called metabolic syndrome. So in an obese or overweight patient, you should screen for metabolic syndrome. And what is MASLD? MASLD. Metabolic dysfunction associated steatotic liver disease. This is the new form, a new name for NAFLD, non-alcoholic fatty liver disease. Now it is called MASLD. So we have to screen SGPT, SGOT also. 2 times elevation is significant, or above 60 is taken as significant. Next.
Abdominal distension, there is increased fat
Truncal obesity with the belly appearance.
Fat deposition around the lower abdomen.
So if the umbilicus is inverted, it may be obesity. If the umbilicus is inverted, it may be ascites also. We will check the shifting dullness syndrome. Next.
Anthropometry. His height is 40 kg against an expected of 28 kg. It's between 90th and 97th centile according to IAP growth, sir. Height is 123 centimeters between 10th and 3rd centile, and BMI is 26.6. It's above 27 adult occurrence. So the child is obese, and his waist hip ratio is 0.94.
So where will you measure waist? It is at the level of upper part of the iliac crest at the end of expiration. And hip, the maximum diameter at the level of greater trochanter at the end of a normal expiration. The waist hip ratio of more than 0.9 is important in a male and 0.8 in a female. Next. That indicates obesity. So the child is obese, and this is the BMI, very high, above 27 adult equivalent. Child is obese with short stature, not coming below 3rd centile. It is not going into the definition of short stature, but definitely it is between 3rd and 10th, lower height. So it is not exogenous obesity. Next.
Systemic examination. In GIT, upper GIT is normal except for dental caries, and lower GIT it's distended and lower abdomen is full. Skin over the abdomen appears normal. Umbilicus is normal in shape and position. No scars, dilated veins or visible peristalsis. All regions move equally with respiration and hernial orifices are normal.
Okay, so there is nothing much in the inspection. Next.
In palpation, there is no local tenderness, no local rise of temperature, no hepatosplenomegaly, no abdominal mass palpable, and there is no renal angle tenderness.
Where is the renal angle?
It's between the lower border of the 12th ribbon, lateral border of the erector spinae muscle in the posterior part.
Where will you get renal angle tenderness?
In pyelonephritis.
Yes. So we are not expecting that here. You can just mention that's all. External genitalia also you have to mention, is there any scrotal edema? Buried penis may be seen in obesity. That also may be a complaint of the mother. Stretched penile length you can mention. Percussion, there is no shifting dullness.
Shifting dullness. Auscultation also normal. In examination of genitalia, it's normal male genitalia, no pubic hair. It's Tanner stage 1.
Okay.
Other system examination within normal limits. There is
So
normal
here
bilateral
we have to look for hypertension features. Okay. So is there any fundus examination? Is there any hypertensive retinopathy we have to look for? And probably investigations like echo will show whether there is LVH. That also indicate chronic hypertension. Child is on long-term steroids and has obesity at risk for hypertension also. There is no focal deficits. Okay. Can you summarize?
9-year-old developmentally normal child immunized up to age with underlying renal disease, probably nephrotic syndrome, which is diagnosed at the age of 2 years. And child is on regular alternate day medication for the past 6 months. Now presented with increased weight gain for the past 3 months and admitted for renal biopsy. There is a past history of recurrent facial puffiness and leg swelling. On examination, child is having features of steroid toxicity, like Cushionot features, truncal obesity and acanthosis nigricans. BMI is more than 27 adult equivalent. Eye examination revealed raised intraocular pressure and systemic examination within normal limits.
Okay. So is it Cushing's syndrome or Cushing's disease?
Cushing syndrome. Cushing
What's the
disease.
difference?
Cushing disease when it is associated with CNS.
Which CNS problem? If it is due to pituitary adenoma, increased ACTH production leading to hyperadrenalism for cortisol elevation, then it is called Cushing's disease. All others are called Cushing's syndrome. Cushing's syndrome includes everything which results in increased adrenal steroid production. Okay, so this is Cushing syndrome, exogenous steroids. Okay, there is acanthosis. Okay, so what was the indication for starting CNI here?
Here the child is having difficult to treat nephrotic syndrome and significant steroid toxicity features.
Okay. So child was on MMF and with that MMF, they couldn't reduce the steroid dosage to a safer level. Child developed glaucoma and obesity. That was the reason for starting CNI. Okay. How long will you wait before rituximab? How will you follow up? The child is now on CNI. How will you follow?
On follow-up, we have to call the child for the follow-up after 2 weeks.
No. After CNI, after 3-4 days, we have to repeat RFT and potassium because acute reaction, acute AKI can occur after a few days itself. That you have to monitor. Then after 2 weeks, one, and then monthly RFT, electrolytes, and we will look for hypertension, hyperglycemia, hyperlipidemia, depending on the case. Okay. And compliance also should be confirm. Will you do trough level estimation?
Yes, madam.
What is that? How will you do that?
After giving tacrolimus, we have to monitor the trough level monthly. And we should keep a 12-hour trough level between
Monthly trough
5.
level, it will be very costly investigation. We are not doing it monthly. If we are not getting the expected response, we have doubt about compliance or an altered metabolism in the baby, we can do trough level or before increasing or hiking the level, drug dosage. It is to be taken, blood should be taken just before the next dose. If they are taking at 8 a.m. morning, 8 p.m. in the night, blood should be taken at around 7 to 7:30 a.m. so that the trough level of tacrolimus can be identified. The same for rituximab also. So the trough level is for cyclosporin, it is 80 to 120 nanogram per ml, and for tacrolimus 4 to 8 nanogram per ml. If that is not there, we can safely increase the dose of these drugs. Okay. And the specific other problem of tacrolimus is seizures and tremors, which is not usually seen in cyclosporin. Okay. And anything else to add? When will you advise genetic study?
Genetic study should be advised if the nephrotic syndrome is infantile in onset, and if there is a strong family history, or we are suspecting any syndromic
I told
association.
family history is not an indication for genetic study unless it is steroid resistant.
We are suspecting SRNS, that is steroid resistant nephrotic syndrome.
And or if there is syndromic features, like a child is having Joubert syndrome, like, or specific syndromes are there which are associated with nephrotic syndrome, then we can do genetic study. And regarding renal biopsy, what are we aiming? What will you do with the biopsy specimen? What are the routine tests done?
Light microscopy, electron microscopy, and immunofluorescence.
For all? They are living in a resource constrained setting. So electron microscopy is not a must for all. We should do light microscopy and IF to see whether there is focal segmental glomerulosclerosis. That is the main aim of doing biopsy. 20 glomeruli should be there to say that there is no FSGS. If we get only 2 or 3 glomeruli, we can't say. It may be there in the other glomeruli. So FSGS, membranoproliferative glomerulonephritis, all this can be identified by light microscopy. IF is to identify IgA, C3 or other immune complex depositions. What is the need of electron microscopy? Electron microscopy is required if you are suspecting basement membrane defects like Alport syndrome or C3 nephropathy, or if you are suspecting in other syndromic varieties, we can do electron microscopy. Otherwise, electron microscopy is not a must for all. So we usually take 2 samples, and electron microscopy, even single glomeruli is enough. Okay. That's all. Anything else you would like to ask? And regarding investigations, we should always rule out tuberculosis before starting steroids. So we should do IGRA. Nowadays, with more than tuberculin test, IGRA is preferred. If IGRA is positive, we should give INH for 6 months. But remember, INH interacts with the steroids and the dosage may have to be adjusted. The response may be less if the child is on ATT. That's it. Anything else you would like to discuss? Regarding edema, how will you manage edema in nephrotic syndrome? Significant edema is there.
If there is significant edema, we have to start furosemide at 1 to 3 mg per kg per day, and we have to add spironolactone also along with it. There is significant edema, and if it is not improving, we can change that oral Lasix to IV at a higher dose.
What is the importance of changing oral to IV? Gut edema. Gut edema will result in erroneous absorption of furosemide. So we may not get the effect. IV furosemide may work better. And the furosemide is secreted into the tubules bound to albumin. So if there is severe hypoalbuminemia, furosemide may not work. So give saline or albumin and followed by furosemide. That may make better response in management of edema. But while giving albumin, remember it can cause CCF. So it should be monitored very carefully while giving albumin. Sir, anything else, sir? Purushottam, sir, anything else?
Emil, points in the history, you said pain as a manifestations of steroid myopathy. Actually, if there is pain, you should consider other possibilities. Weakness will be the manifestation in a steroid myopathy, not pain. Pain, if it is the steroid-induced osteoporosis or slipped femoral epiphysis, something like that should be considered. In the marking, in the growth chart plotting, in this case, the weight is much higher than the expected. 28 was the expected, it was 40 kg. But the height is on the lower side. So most probably it is a steroid toxicity. But any growth chart, you should be plotting the mid-parental height. So that was lacking. In that growth chart, you didn't record the mid-parental height with the centile of the height was a 10th centile. So a child with a heavy body weight but a stature on the tensile, it makes some sense only if the mid-parental height is plotted. Always plotting of the mid-parental height is important. And in a condition where there is short stature, there can be an associated endocrinological problem. Always in the history mention all the features of hypothyroidism. In the examination also, you need to check for the physical findings of the hypothyroidism, especially the older child, the slow relaxation of angle. And in this case, what was the pulse rate?
80.
No, 80. There is no tachycardia.
Okay, tachycardia and bradycardia also. So tachycardia for hypovolemic situations, bradycardia indicate maybe hypothyroidism. So subtle findings are important. You need to consider other possibilities of obesity always. It need not always be due to Cushing syndrome, steroid induced. That is definitely one of the possibility, but other possibilities should never be missed. In the genital examination, that is very important. All the things which you discussed, touch penile length, it can be other manifestations of the hypogonadism. SMR need to be mentioned. All the other things were considered. One doubt regarding the immunization we considered in this time it is a dog bite scenario. So in this child, suppose there is a bite, what way the management will be different?
If it is not a live vaccine, what we mentioned was regarding live vaccines. So other vaccines can be given, but the effect may not be very good depending on the degree of immunosuppression. So all the recommendations, contraindications were regarding live vaccines. Others, immunoglobulins and all will work. And the vaccine take may be less. And for hepatitis B, they are telling accelerated immunization. Double the dose can be given to increase the immunogenicity. Regarding rabies vaccine, I don't have such idea whether double dose.
It's always IM, that is a recommendation.
Okay.
IDRV should not be given. Always IM schedule, that must be five doses, not IDRV, not 4 doses.
Okay.
And one more thing, in a case like this, in a bite happening after the pre-exposure or a post-exposure completed prophylaxis, there also you need to give IV gamma. No other situations you need to give IV gamma. Only 0.3 single site IDRV is a recommendation. So in this context, it is relevant. That's all.
Okay. So Krishnan sir is there? I didn't see sir. Mohandas sir, Krishnan sir is there?
Fiji, it was a very good discussion. So in the diagnosis, is it better to mention what type of nephrotic syndrome it is, whether it is frequently relapsing or steroid dependent or steroid resistant?
That she mentioned frequently relapsing.
It is frequently. Okay, it is there. Okay.
And
Then-
probably minimal change itself. That also
Mhm.
could have been mentioned.
Okay.
We are not suspecting any significant lesion nephrotic or no other clues are there. Sir, Krishnan sir is there?
And
Mohandas sir?
is there any role for also in the management looking for the bone mineral density, giving this bisphosphonates, such things, is it indicated? And also in the clinical examination looking for any features of vertebral compression, pyramidal signs, like that?
So for that, we are routinely giving calcium for all those who are on long-term steroids. For frequent relapses, we are giving 500 milligram maximum dose of calcium per day. So we are not having much problems with osteoporosis or fractures. We are not at all seeing such cases. If that is not done, probably this bone mineral density testing can be done.
Because in children
And
with
for
the-
steroid resistant nephrotic syndrome, we can expect loss of other binding proteins also. So we are giving vitamin D also for steroid resistant nephrotic syndrome. Thyroglobulin, vitamin A binding protein, all can be lost. So we are supplementing those in SRNS. That is totally different from steroid sensitive nephrotic syndrome.
In the evaluation, I mean, always you should mention about the gait, because there can be multiple reasons for the gait problem in a child like this. One of them is, you already mentioned, proximal myopathy. The second one is, again, there can be hip problems, long duration leading. So, slipped femoral epiphysis and proximal myopathy, the gait will be waddling gait.
vascular necrosis also.
Yes, yes. You ask the child to walk in front of you. You ask the child to sit and stand. You ask the child to stand on one foot. All these simple things. Mohandas was already pointing out the use of reflex. There are multiple ways. These are all relevant. The reflex elicitation is important. Is it a sluggish in a case of myopathy? If there is a vertebral collapse, it can be pyramidal signs. In a case of thyroidism, it will be slow relaxation. So, the importance is there for the other system examination also. Srinivas sir, any comments, sir?
Yeah, I just enjoyed learning all aspects of nephrotic syndrome according to the current protocol. Yeah. So very well presented, excellent discussions. So enjoyed. Yeah. Learned a lot. Thank you.
Thank you.
Thank you, sir.
Can we wind up? Because
Yes.
time is already 9:20. So I think Emil has answered very well.
Yeah.
Okay, good night for all of you.
Thank you, sir, for giving this opportunity. Okay. Thank you for the input, sir. Purushottam sir, Mohandas sir, Srinivas sir.
Thank you. Good night.
Thank you. Good night. Good night.
Thank you.
Thank you, Emil. It was well presented.
Yeah.
Thank you, madam.